So my name is Jessica Tess, and I am the social media specialist on the CAPE project. CAPE stands for Community Assessment to Promote Behavioral Health Planning and Evaluation. We're dedicated to identifying and sharing best practices for benchmarking community behavioral health. We're in partnership with the Substance Abuse and Mental Health Services Administration and USDA National Institute of Food and Agriculture, as well as the North Central Regional Center for Rural Development at Michigan State University. So today our speaker is Adam Sonfield. He is a Senior Public Policy Associate at the Guttmacher Institute, and he will be presenting for us Return on Investment, a fuller assessment of the benefits and cost savings of the U.S. publicly funded family planning program. So if you have any questions as we're going along, feel free to put them in the chat box. I'll be fielding them along the way, but we will have a Q&A session at the end. So without further ado, I'm going to hand this over to Adam.
Thank you. Looks like we don't have quite a large audience yet. Hopefully people will keep coming on as I start talking. Some of you may be familiar with Guttmacher. I see a few friends on this list already. Others of you may not be. Guttmacher is a think tank devoted to expanding sexual and reproductive health and rights in the United States and abroad. We do research, we do policy analysis, we do public education, and we pull those strings together to try to promote health. I'm in our DC office, and I'm a policy analyst there. I'm also occasionally a researcher, and I was one of the researchers on the report I'll be. And since some of you are probably not as well versed in the family planning world as I'm used to in terms of people I talk to, I'm going to give you a bit of an overview first about the importance of family planning, about the origins and scope of the U.S. publicly funded family planning system. And then I'm going to dive into an analysis that we put out late last year that is our fullest assessment yet of health benefits and the cost savings from the U.S. publicly funded family planning program. So let me get started on that. Let's try that again. There we are. So let me talk a bit about, as I said, the importance of family planning. Since not all of you are family planning focused experts here, it's something that you may not think about it as much as something you may not think about all the time, as much as I do certainly. But the average American woman wants 2 children, and for that to happen, she needs to spend something under 3 years pregnant or trying to become pregnant or postpartum. But that leaves, on average, 31 years that woman has to spend avoiding pregnancy. The average age of first sex is a bit under 18, and the average age of menopause is around 51. That's a lot of years where you have to try to avoid an unplanned pregnancy, and that's not easy to do that. Yes, contraception is available, and the vast majority of heterosexual women do use contraception at some point in their lives. And at any given time, about 60% of women of reproductive age are using contraception. But being able to use contraception effectively and consistently all throughout your life in a way to ensure that you never have an unplanned pregnancy can be really difficult. And that's why there's been a lot of effort going into supporting women and couples in their contraceptive efforts. There are a lot of good reasons to support this. There are a lot of important social and economic reasons for helping women and families plan their families. This slide shows some data from a study from a couple of years ago that Guttmacher did was a survey of women, asking them why they were using contraception, what they thought it was, why they thought it was important in their lives. And you can see that um, the most of them agreed with the idea that being able to use contraception has helped them to take better care of themselves and their families, and to support themselves financially, and to stay in school and finish their education, and to get or keep a job and have a career. And those are impacts that it's not just what women themselves say, that they believe this is true. We've also seen plenty of research out there helping to demonstrate those impacts. Um, those are the social and economic impacts. You also think about the health impacts, because contraception does have real health impacts in terms of helping to prevent unplanned pregnancy and to plan wanted pregnancies. Um, so yes, having contraception helps you plan those pregnancies, helps you avoid, for instance, closely spaced pregnancies. Ones that are closely spaced are more likely to result in low birth weight births and preterm births. Birth spacing is important to be able to get healthy before you get pregnant. Thinking about preconception care, make sure you are getting prenatal care from the very beginning of your pregnancy. Making sure that you follow up with postpartum care after you give birth. Um, and women who plan their pregnancies tend to have better, more healthy behaviors while they're pregnant and afterwards. In terms of things like quitting smoking and going to prenatal care early, and not drinking, and breastfeeding when after they've given birth. Um, and we know that that's good for maternal health, and it's also good for their children's health. Um, not just about preterm and low birth weight births, but more broadly about child health outcomes going forward. Things like breastfeeding are very important to that. So those are the health impacts. For both of those sets of reasons, the social and economic impacts and the health impacts. For those reasons, the federal and the state governments have spent quite a bit of effort and over many decades trying to support women, and particularly lower income women who have the greatest financial barriers to contraception. They've been trying to help them to practice contraception consistently and effectively. Um, so U.S. investments in family planning date back to the 1940s, when some of the early maternal and child health grant programs, those funds were able to be used for family planning services, and they were in several states. Um, they started picking up more in the 1960s. There were some dedicated family planning grants from the U.S. government through its anti-poverty efforts. And around the same time, Medicaid was created. And under the original Medicaid law, states were allowed to cover family planning services. That was an optional service. By 1970, things had really picked up steam. Um, the Title X National Family Planning Program was enacted that year. That had overwhelming bipartisan support. It was promoted by President Richard Nixon. Its chief sponsor was George Herbert Walker Bush. Um, and it maintained that strong bipartisan support for many years afterwards. Um, by 1972, there were some additional important changes, including um, advancements under Medicaid. So under a law passed that year, state Medicaid programs were then required to cover family planning services and supplies, and they were given incentives through an enhanced federal matching rate to cover as broad a selection of methods as possible. And that's where the current day effort comes from, is some of that groundwork laid in the 60s and the 70s, and it's continued. So today, by our last count back in 2010, about 9 million women are served through publicly funded family planning providers. That's just in 2010. You can see from this chart, the bottom bar on here, that most of those women are served through health centers. and about half of those women serve specifically through health centers that receive funding through that Title X family planning program. You can see the green segment on the right are private doctors and other private healthcare providers who are serving Medicaid patients and providing them with family planning services. So that's sort of the distribution more broadly about who's getting those services from where. Um, when you narrow that down to thinking about the clinic system, the safety net clinics I was just talking about, um, you can see there's a wide variety of different types of health centers that provide family planning services in the United States, about 8,400 of them nationwide in 2010. Um, you can see from the top bar that the greatest single chunk of those are from federally qualified health centers. That's the gray bar on the right. And then that blue bar there in the middle is health departments, usually county health departments. You also have Planned Parenthood affiliates and hospital-based clinics and a bunch of independent family based health centers and other entities like that on that other category all the way on the left. Um, it's interesting just to keep in mind that that different types of clinics have a different focus, of course, on family planning. FQHCs have a broad primary care mission, and family planning is a part of that. It's a required part of that under federal law. Um, but naturally, they spend a lot of time serving clients for other reasons as well. And so they don't make up the bulk of family planning clients served. So you can see that 38% of FQHCs clinics, they only have 16% of the share of clients. The Planned Parenthood affiliates, by contrast, they tend to be very focused on family planning services naturally. Though they make up a small percentage of the share of all health centers, they make up more than a third of all clients served. Talk a bit more about the system and specifically about where the funding comes from. So again in 2010, there was about $2.4 billion in public dollars spent on family planning in the United States, services provided in the United States. About 3/4 of that was through the Medicaid program, which has become, over the last several decades, has become the dominant source of public funding for family planning, just like it is for many, many other services in the United States. Medicaid's role has expanded quite a lot over the last several decades. There have also, specifically for Medicaid, for family planning, been, and about half the states have adopted expansions to Medicaid specifically for family planning services, and those are for women broader full benefit Medicaid. They may be eligible just for family planning services, just in the same way that many women are eligible for pregnancy care under Medicaid, well above what are normally set for Medicaid in that state. You can also see on this chart several other major funding sources. Title X is on there. There are many states appropriate separately money for family planning services. That's the blue segment there. There's a small segment there for other federal sources that includes the block grants, the Maternal and Child Health Block Grant, the Social Services Block Grant, temporary assistance for needy families. All of those can be used for family planning services, and they still are in some states around the country. Major source of funding at this point. And last, before I get into the meat of cost-benefit analysis that I want to talk about, let me bit of background on the Title X program, since it is core to the family planning effort in the United States. As I said, it's not the biggest source of money at this point, but it still is very important as a source of funding for some clients who are uninsured, who are underinsured, since Medicaid and private insurance don't necessarily cover every service that you would want. And some of that is meeting the needs, specialized needs that many women and men have. Intensive counseling that you might need for someone who's never used contraception before, who's never pap smear before. For people who are facing serious challenges in their lives related to mental illness or related to substance abuse or interpersonal violence. There are many specialized needs that family planning clients and Title X and other grant funding like that is very helpful for helping those clinics meet those. It's also helpful for helping them to staff their clinics and support the infrastructure, building clinics themselves and keeping information technology up to date and all sorts of things like that. Um, Title X is also important for establishing the core principles providing publicly funded family planning services. Establish the principles that family planning care should be voluntary and confidential and affordable and effective. And those are principles that even other providers who aren't receiving Title X money very much try to strive for. The Title X program has also helped set standards of care for family planning. And the CDC, along with the Office of Population Affairs, which is the agency that runs the Title X program, together came out with some new standards of care just last year, quality family planning standards, which are really trying to set nationwide standards for the provision of family planning care, regardless of the setting, regardless of the funding source. Trying to lead the way all throughout the country. So it's not just about the concept of methods and the services providing that doctors and nurse practitioners provide. It's also about histories and assessments and screenings for lots of different conditions and counseling and referral. And it's not just about do you want to become pregnant, or are you there to because you're fearing you might be infertile, or are you thinking about preconception care because you are hoping to get pregnant sometime soon. All those pieces are the reasons why people come in for family planning services. But part of the standard of care in these clinics is to try to screen for other important primary care health problems, things like interpersonal violence, substance depression, and partly because those issues are very important for determining, for women's ability to practice contraception effectively and for choosing a method that might be right for that woman. She's worried about interpersonal violence. She may want to be thinking about a method that she can hide from her partner, unfortunately. But it's also about referring women and men to other providers when they are diagnosed. When there's, when you screen a woman and you find that she is having a substance use issue, being able to connect her to care for that substance use issue is very important, and it's part of that standard of care. And it's one of the ways that family planning links up with many of the other pieces of the healthcare system, including health issues that I know many of you are involved with. Let me move on and talk about our study on the impact of. So Guttmacher has done research on that topic for several decades now, but traditionally our scope has been somewhat narrow. We have focused on the impact of contraceptive use in preventing unintended pregnancies and their outcomes, unplanned births and abortions and miscarriages. And connected to that is what are the cost savings to Medicaid and to the Children's Health Insurance Program and other healthcare programs that might pay for maternity care and infant care. Don't prevent those unintended pregnancies. That's been our traditional assessment, and it's been very widely used and widely cited and very effective in making the case for public. But we've known that it's not by far, it's not the entire impact of these services, because as I mentioned before, there are this whole wide range of social and economic and health impacts from publicly funded planning. And so we wanted to think about, can we start to quantify any of that? And so we started off doing literature reviews, naturally. Some of that was thinking about the social and economic benefits. I mentioned before that there are benefits in terms of being able to stay in school and get a higher degree, um, um, help you to find and keep a good job, and to help support your family, to help raise your children the way you want to raise them with the support you want to be able to provide them. Even strengthening relationships, strengthening marriage. Pregnancies can be a major source of tension in a marriage. Um, and there have been numerous studies over the last several decades trying to quantify these impacts. We looked at that. We also looked at, again, women's own reasons for using contraception in their own words. Um, Probably more promising for what we are looking at, really, for trying to quantify that impact, is to think about the health impact, because some of those health impacts have been, there's a lot of really strong literature on the impact of HIV screening and chlamydia and gonorrhea screening, and things like vaccination for the human papilloma virus, which is a virus which causes cervical cancer. And the impact of Pap smears and HPV screening to help identify precancer before it becomes cervical cancer, and to help head that off. Um, there's been a lot of research on the impact of those different services over the years, and what we wanted to do was to apply that research to the services provided as part of a publicly funded family planning visit, and talk about the impact that that is more broadly. And so that's what we did in this study. As I said before, we started off talking about contraceptive care and thinking about what that means for unintended pregnancies averted, um, and the idea there is we are trying to compare the outcomes of women, right, given the current publicly funded family planning effort, try to compare that to a hypothetical situation of what would happen in the absence of those services. And obviously, in the absence of those services, this doesn't mean that every single one of those 9 million women is going to suddenly stop using contraception. That'd be ridiculous. Um, what we do know instead is that, sure, some of them will be unable to afford any method at all. A lot more of them will end up switching from a method which is more expensive and requires a doctor's appointment, something like the pill or an IUD, and end up having to instead use a method which they can find more readily available, something like a condom, or using withdrawal, pulling out. Those are important methods of contraception in their own right. They have their own advantages, but on average, they tend to be quite a bit less effective than the prescription methods that are out there. And so what that means is that you're more likely to have an unplanned pregnancy, um, all the consequences that might result for it. And that's the same approach we took to the rest of the study, is trying to think about what would happen in the absence of these services. So we were able to add on some more information about poor birth outcomes, about the impact of contraceptive care on preventing those poor birth outcomes. So preventing poorly spaced births, births that are less than 18 months between a birth and the next pregnancy, which, as I mentioned earlier, increases the risk for things like preterm births and low birth weight births. And those are also outcomes that we looked at. And also, we looked at some of those outcomes averted by those other family planning services. So chlamydia and gonorrhea and HIV infections averted. The health impacts from some of those STIs, things like pelvic inflammatory disease and ectopic pregnancy and infertility, all of which can result from chlamydia and gonorrhea. Also looking at cervical cancer cases. So that was the goal here. And we were able to estimate numbers for many of these services. So Those 9 million contraceptive clients served in 2010, from those services, we've estimated that about 2.2 million unintended pregnancies were averted just from that single year of services. And those would have resulted in about 1.1 million unplanned births, 760 abortions. The rest of those would be miscarriages. And beyond that, of those 1.1 million births, nearly 300,000 would have been closely spaced, and 160. You can also see on the right here that we've broken out the impact just point out that important role of Title X. We also have estimates now of the impact of the STI testing of chlamydia and gonorrhea as part of a family planning visit. Obviously there's plenty of STI testing, plenty of HIV going on in other contexts by other providers. Really the testing done as part of just from that set of testing, we're talking about chlamydia infections averted every year, 16,000. 400 HIV infections I have on here. And, that doesn't sound like a lot, but as you all know, the health impact of each HIV infection and the cost savings as well can be tremendous, just averting a single. And again, thousands of cases of PID, and ectopic pregnancy, and infertility. Pregnancy can be deadly if it's not treated, if it's not caught in time. And as I mentioned before, we also looked at the impact of Pap testing. And combined, that led to nearly 3,700 cases of cervical cancer. And this is the testing done as part of a lot of other Pap tests being done by private doctors all around the country and through private insurance. Done elsewhere. This is just the testing and vaccination done as part of. Considering that there are only about 4,000 cases of cervical cancer every year, you can see how important Pap testing in particular has been. And all that combined means about over deaths from cervical cancer averted, again, by those services. I mentioned before that we've also traditionally looked at public, to taxpayers. Traditionally, we had looked only at maternity care, 12 months of infant care, and we were thinking about Medicaid pays for nearly about half of all births in this country. I know that can be a shocking number for people who haven't heard of it before, but about half of all births and about 2/3 of unplanned births. So being able to cut down on the number of unplanned births can be a real cost savings for the Medicaid program. We have expanded that now to go out and also to bring in care for miscarriage. Abortion is not generally covered by Medicaid. It's banned under federal law, but states are allowed to use their own money to provide abortion coverage for women on Medicaid. And beyond that, as I mentioned before, we had all those other services that we're looking at, those testing. Looked at the cost savings. You can see that, not surprisingly, the savings from contraception still dominate. We've always known that there are tremendous savings. we're getting to about 15.8. Backed out, of course, the cost of the program up with is 13.6 billion government savings just from the services provided in 2010. Dollar spent, every dollar invested in family planning, and the government ends up saving about $7. A very strong government investment out there where we have that type of evidence. So as I said, this came out. We released this in last fall, a big article in the Milbank Quarterly. Walk through the methodology for this. It's a very extensive methodology, as I said, drawing on dozens of other research articles that have come out, applying those findings to tests and things like that. And we did that at the national level and at the state level. Article that can help, that can show the impact of these services at the state level. We've also created a bunch of additional tools coming off of this study. And try to put it into a context as part of our sorry, got distracted there for a second. As part of the Guttmacher Policy Review, which is our policy journal that the Guttmacher Institute puts out quarter. We also have fact sheets drawing the study and pulling it together with a bunch of other Guttmacher Institute resources. And we also have a special tool that we have on our website. Say an individual planning provider, an agency, to put in their own data. So they would select the state that they are in, and then they would enter data about their own clients. So clients they've served in that year, and the tests they provided for chlamydia and gonorrhea and HIV, and the number of vaccinations. It would then generate numbers, generate estimates they provided. And there's a tool for healthcare providers to use and for advocates to use to talk about the importance of publicly funded therapy, to talk about the importance of having those healthcare clinics as part of I think that's pretty much all I wanted to talk about today. I know we have plenty of time for questions, which I hope we'll have some questions. Our website is here on this last slide, www.guttmacher.org. We have plenty of resources there. I'm happy to take some questions now.
Yeah, thank you, Adam. And we'll give people a minute to think if they have any questions and put them in the chat box. In the meantime, I have a question, which is I'm curious on a national or a state level or even like a local county level, how much do you think some of these outcomes that you mentioned related to family planning, such as screenings for depression, substance abuse, STIs, how much do those types of outcomes get discussed at any of those levels compared to, the more direct ones like abortions and unintended pregnancies?
Yeah, it's a great question, and those were some of the pieces that we really were hoping to be able to put into the study, and realized pretty early on that the data just weren't there to be able to talk about the impact of that screening. But we do know that family planning clinics are a really important entry point to the U.S. healthcare system, and we have a number of different statistics talking about um, how family planning clinics serve as sort of that gatekeeper, where it's the first place that many women go to for healthcare, and in many cases the only place they go to for healthcare here. And so if they're not getting the screening there, they're not getting that screening. And so family planning clinics for a long time have worked to connect their clients to care by having referral arrangements with, and also to connect them with health insurance coverage and to make sure that they have for full benefit coverage under Medicaid, under private. Many of those clinics have done enrollment assistance, in particular under Medicaid, and some of them have even served as navigators under the new under. Um, and I know there have been certainly some thoughts about how do you evaluate those referral arrangements, connections, um, under some of the new payment reform arrangements that we have in this country, things like where we are trying to better make those connections between care providers and specialist providers, trying to make those connections between health. Um, and hopefully we'll be seeing a lot more in terms of get more robust and better measures for that going forward.
Yeah, very interesting. So I was curious, you said that there was this really strong number of, $7 for every one that gets invested that in savings for this program. Given that's the case, is this program going to be continue to go strong to be funded in the country? Because of course recently there's been some pushback for different topics related to family planning.
Yeah, there certainly has been a lot of pushback. Um, that's a pretty recent development. As I said, family planning services in the U.S. had for many decades been very much supported by people on both sides of the political aisle. Had a lot of support at the federal government, by the federal government and at the state level. But there's been um, something of a shift. The Republican Party has gotten quite conservative over the last number of years, and Congress in particular has become quite a bit more conservative. And it has unfortunately put family planning in more of a difficult political light than it had been in the past. There have been some concerted efforts by some anti-family planning to try to blur the line between contraception and abortion, and as a way to tar family planning and to tar the providers of family planning services in this that we push back on. And this type of research we do believe helps, talking about the health impacts and also talking about the financial impacts. Although, as we always try to emphasize, the health impacts are why you do this in the first place. The financial benefits are a bonus. And in fact, I think we have a question in here from someone on the call asking about saying you're making a financial argument here, and to what extent do policymakers respond to numbers versus stories. Um, I know there's a couple other questions in here as well, and I'll take them one at a time. Let me take that one first. Um, I think that question, numbers versus stories, is I think it's the answer is always both. Um, it depends on it depends on the policymaker. There are some policymakers who are all about the numbers, and some of that is all about the public health numbers, and thinking about um, family planning as helping to prevent abortion and to drive down the abortion rate, or to help get at the problem of preterm births and low birth weight. And we have a lot of support from policymakers over the years because of that impact. We also have policymakers who really care primarily about the bottom line and are very focused on government finances. And those numbers are helpful there. It doesn't always work, those arguments, in part because um, the way budgets are done at the government level, it's hard to look more than a year down the road. You really, budgets often, they focus so much on current year savings, and as we know, trying to show current year service is difficult. For family planning, it's not as difficult as for some other ones because it only lasts 9 months. So you can see some outcomes, see some financial savings, within a year. But some of the longer-term health outcomes we're talking about here, thinking about savings to Medicare and Medicaid from averting cervical cancer. It's not a small amount of money, but it does tend to happen well down the line. And there are plenty of other policymakers who very much are focused on the stories and who are, who are can be convinced by a couple of anecdotes in a way that they'll never be convinced by numbers. One of the reasons that that Guttmacher, our focus on the data has been a valuable contribution to advocacy efforts, but it's certainly nowhere near the only thing that advocates rely on. And many advocates do a tremendous job of telling those stories and making that more emotional. I have another question here from my old friend Linda Wheel. Hi, Linda. Linda's asking, as we start seeing increased LARC utilization, LARCs are long-acting reversible contraceptives. Those are the most effective methods of contraception. And Linda asks, is it possible to come up with a return on investment with a focus on LARC use? Linda, that is something that is absolutely something that we are working on. It won't be coming out quite so soon, but trying to think about that mix of contraceptive methods. How do you account for the idea of shifting women and couples from relying on methods like the condom, which is great for STI protection, but not so great for pregnancy prevention on average. Shifting them towards more effective methods like the pill and maybe something like an IUD implant, which are extraordinarily effective because very little room for user error. I mean, that's really why the pill is not always as effective as it could be in practice, is because women end up sometimes missing their pill. They may, you have to get it around the same time every day, I certainly allergy medicine every day, and there are plenty of days I miss my allergy medicine. I just forget about it. You forget about your pill, the contraceptive pill, and it could put you at risk of an unintended pregnancy. So methods like an IUD are much more effective in that sense because you don't have that possibility for missing a day. But yes, it's something that we absolutely hope to do as a follow-up to this study, is to be able to dig a bit deeper and to think about what change that mix of methods. And that, though I'm not going to promise. Other questions? I have nothing else at the moment in my queue.
So far, I haven't seen anyone else typing. So if you have a last-minute question, start typing it so we can see it in the chat box. All right, well, thank you, Adam. This was very interesting for a variety of health issues, and especially, as we saw, behavioral health issues. So the recording of this webinar will be available at the Health Bench website on our webinars tab. We do have one last minute question from Therese. She would like to know if the references will be available after the talk. Adam, if you could send me the references, we could also post them to our website next to the recording. How does that sound?
That'd be great. I'll send you a link to the main study itself, and that study has an immense number of references in there. Those of you who really like to dig deep into that research detail, you'll enjoy. For those of you who don't, I will also attach a link to my policy article, which gives much more of a user-friendly summary of that. We'll do a collection of resources, um, and um, and as always, Guttmacher is available to provide further information if you have more questions. And it looks like, nope, Teresa was typing again, but it looks like that isn't. There we are. I think that's it then. Anything else, Jessica?
That's it. Thank you so much, Adam. And thank
Thank
you to
you.
everyone who showed up today.
Absolutely. Thanks for all for